lab results I got from the rhesus monkey.
Oh wow, those are looking really good.
This is from what we did last week. These are the drug results we gave them, the drugs we gave them last week. I think if this continues, human trials. How long do you think?
Awesome. I think probably we could do like 3 to 4 months, you think? Maybe?
That sounds, we'll just keep doing this. We have to keep getting these results though. If this works, this will change the face of humanity.
We'll finally be able to cure this worldwide epidemic.
Yes.
Austin.
What?
Dr. Austin, something's wrong with subject 4.
Subject 4 is our female, right?
Yes. The tonsils are compromised.
What's wrong with them?
I ran an SBB and an ESR and they're sky high.
What do we need to,
The tonsils are necrotic.
No! She needs those tonsils to survive!
We're gonna have to do something.
Do you think,
We'll have to.
I guess it's gonna have to be a transplant. We'll call in all the specialists, monitor that rat, do not let her die.
Okay, got it.
That's me in the corner. That's me in the spotlight. Losing my religion. Something, something, next word, yeah! Right, back to work. What's that noise? Wait, oh, that's my phone. Where do I put that thing? Oh wait, found it. Sweet. Hello?
Dr. Hilton,
Yeah?
I know you're really busy in Ethiopia right now, but we need you to come be our anesthesiologist for our surgery.
Who is this?
This is Dr. Emanuelson. We're doing the research on the rats.
Oh, yeah, Dr. Emanuelson. Yeah, good to hear from you. Yeah, I'm kind of way out here in the middle of nowhere. I'm starting to go bananas. It's getting crazy over here.
We have your plane booked right now. You just need to be at the airport at 7.
Airport at 7. 7 your time or 7 my time?
Your time. Get to the airport. We need you to be here for our surgery tomorrow.
Airport. Surgery tomorrow. You got it. Anything else?
That's it. Thank you so much.
You are welcome. I will be there.
Alright, Dr. Garner, thank you for joining us on such short notice. Earlier this week, Dr. Shaw found some alarming test results in subject 4. We have to do an emergency tonsillectomy. Dr. Hilton will be here tomorrow. Right now he is currently in Ethiopia. Dr. Johnson created these rats and she did all the genetic engineering work for them. So we have her on speakerphone and she's going to join our conference and tell us about all of the genetic problems that we may face with this transplant. Dr. Johnson, you're on.
Hello, Dr. Austin.
How are you today, Dr. Johnson?
I'm good. How are you?
I'm good. Could you please tell us, I know these rats are allogenic because the synogenic subjects you created were sterile. Can you tell us what we need to worry about with this transplant?
The biggest problem to watch out for is rejection of your graft tissue. There are 3 types of rejection that you may see, Dr. Austin. The first one would be hyperacute rejection, and this one occurs within minutes after your transplant. The symptoms of this would be thrombosis of your graft vessels, ischemic necrosis of your graft. This type of rejection is mediated by circulating antibodies, which are specific for antigens on graft endothelial cells that are present before your transplantation. Your second kind of rejection would be acute rejection, and this type of rejection occurs within a few days or weeks after your transplantation. It is mediated mainly by the T cells, which react against alloantigens in the graft. CTLs are responsible for this, and they directly destroy the graft cells, which may react against the cells in the graft, leading to vascular damage. And the third type of rejection would be your chronic rejection, and this occurs over months or years. Symptoms of this would show fibrosis of the graft or arteriosclerosis, which is narrowing of your graft blood vessels.
Alright, thank you, Dr. Johnson. Is there anything else we need to know about?
No, I think that's it, but I'll call you if I find anything.
Alright, have a great day.
You too.
Dr. Hilton, thank you for joining us. I know you've been extremely busy in Ethiopia. We've already discussed the different genetic problems that we could have. We are going to talk today about different recipient things. We have all of our lab results from Dr. Shaw, and I need you and Dr. Garner to discuss the anesthetics of this surgery and what will happen to the rat after the surgery is over, and the different effects that anything that we might have to give them as far as antibiotics and drugs will go. So first, would you like to give us the lab results?
Of course. Alright, subject 4. The CBC results were very favorable for transplant. The MCV, which checks for the volume of red blood cells, the MCHC, which checks the concentration of hemoglobin, and the MCH, which is the average weight of hemoglobin, were all very normal. The hemoglobin was 14 and the hematocrit were 40%, which are very normal for our female rat. The platelet count was 350,000, very favorable. Our electrolytes were also normal. We definitely had to check sodium, potassium, and calcium, which are very important as far as all organs in our transplant go. For viral testing, we had to test our rat for hepatitis, cytomegalovirus, Epstein-Barr virus, and AIDS, and all of these results were negative. And then we had to test subject 4 with tissue typing to indicate whether or not the transplant will be successful. We tested HLA, which is the human leukocyte antigen, which is also found in rats, and it tests for the probability of rejection, and this result was very low. It indicates that we have a low rejection rate. We also did a mixed leukocyte test, which is the same result. We got a low rejection rate. We also ran a PRA, which is panel reactive antibody, and this result was 20%, which indicates a low possibility of non-self rejection. We also ran a cross match between subject 1 and 4, and we tested their serums together, and there was a good match and no rejection.
Would that solve the problem of an immunologic cross reaction?
It would, yes.
Okay, fantastic.
And all of my lab results have indicated that subject 4 is a great candidate for transplant.
Wonderful. All right, subject 4 weighs 0.8 kilograms. I know that y'all need this for your, to determine how much anesthetic the subject 4 will need. However, subject 1, the donor, is 0.85 kilograms. I'm not sure if that will change anything for y'all. The reason that we have to be very careful is that the MHC markers are the single strongest immune response that we have during a transplant. If the MHC complex does not resemble the self-MHC complex of the recipient, we could have serious problems. This can happen. The CD8 cells will attack, and it will cause an MHC restriction by both CD4 and CD8 cells. And that will cause the cross reaction that I was discussing with you a minute ago. There's also a chance of a direct reaction. Dendritic cells will take in a small portion, and they will bring it to a T cell, and that will cause rejection. Indirect recognition is due to ingestion of some of the donor molecules, and this will cause the same cross reaction, and it will stimulate T cells to attack the foreign organ. This is the biggest problem I believe we have with that xenotransplantation would be the MHC complex. What type of anesthesia are we going to have to worry about? Antibiotics, drugs, and so forth. What do we need to take into consideration, and what are we going to use?
Well, for the anesthesia, it all depends. How long do you want the rat to be under and anesthetized?
What do you think is a safe? I think it will take 30 minutes to an hour for the surgery.
I would say we would want to do no more than 2 hours because this could affect the blood pressure of our rat, so we definitely need to be careful.
Alright. Are there any other side effects?
Cessation of inhalation.
Okay, we'll have to watch that very carefully. Do you need any other information? What do you need from us to have our setup?
You said the surgery will take 30 minutes to an hour.
I believe so, yes.
I think
any complications.
According to my experience, I think it would be safe to go ahead and have it knocked out for about an hour and 30 minutes. That gives you 30 minutes of leeway time in case something goes wrong.
Okay.
In case, it has impaired breathing or a higher blood pressure, you can take that into accordance. The time to take that, set down. So that just leaves the questions of, how much do the two subjects weigh?
Subject 1 weighs kilograms, 85 kilograms, and subject 4 is the recipient. Subject 4 weighs 0.8 kilograms at this time. Both of these rats are of breeding age, and it is very important that we get them well as soon as possible because we need to proliferate these subjects.
Okay, so you're looking at a 0.05 difference in weight.
Yes.
Okay, that's not that big of a deal. It should not take long. I'd say the anesthetic we use is one that I've used a lot. Its trade nickname is White Lightning. It's pretty fast acting and works really well. Keeps them out and ready, and little side effects afterwards, you know. But that's same with any anesthetic.
What type of side effects are we
Like
talking about?
they're gonna have pain depending on like where the surgery is, because you know what you're essentially doing is numbing the neurons. So they're gonna have pain, nausea, because the along with the anesthetic, we give them certain medications that essentially stop gastric function so that you know they don't.
Okay. Now
Yeah.
we are going to stop. We are planning the surgery for tomorrow. Have we already stopped their feeding cycle
We have,
for today?
yes.
Okay, fantastic. I have one more question about the anesthetic before we go into antibiotics. Will it be a problem having both of our subjects put to sleep at once?
No.
Okay.
They'll be on separate systems.
Alright, fantastic. Alright, antibiotics. How is that going to affect our organisms?
Well, obviously you're you know cutting open and having a just open area for you know particles and microbes to enter into the body. So you're gonna have you know skin antibiotics like iodine, which will kill all the bacteria on the skin for when you first go into your subject. You're gonna be in their IV. You're gonna be giving them intravenous antibiotics to help go through the bloodstream and help kind of pick up their you know antibodies for during surgery. Now you're going to be using kind of special antibiotics obviously because you don't want the fast acting and quick out of the body, because you don't want them in the system for after the transplant, because you know you're gonna be giving them immunosuppressants, so why boost their immune system to you know kick it in the nuts. So going on, she I think has the actual immunosuppressants that are normally used after surgery.
Alright.
So
Are these going to... How much is this going to hurt our subject's immune system? And do we need to give antibiotics to both rats? Only one is receiving a transplant, but they're both going to be in surgery, so chance of infection for both of them is there.
they're both going to get antibiotics, yes, but the difference is your subject
For so the recipient?
subject 1, your donor, is going to be given another antibiotic after surgery.
Okay. Alright.
Right. As far as suppressing the immune system after the surgery, the most commonly used immunosuppressant is cyclosporine, which works to block the T-cell cytokine production by inhibiting the in-fat transcription factor. So,
Is that with the signal transduction pathway?
yes.
Okay.
We're going to try to start with cyclosporine, and then if that doesn't work, there are several other options that we can still try, such as rapamycin. If, as Dr. Johnson was talking about with the acute rejection, if that does occur within the few days or weeks after the transplant, then we need to switch the rat over to antithyomycite, and that's going to be a little bit stronger and will help decrease the chances of another rejection occurring. And how that works is it just promotes the phagocytosis, or it complements it with the complement-mediated lysis.
Alright, we already plan on keeping subject 4 and possibly subject 1 in an isolated and sterile environment, at least till subject 1 heals, and subject 4, I believe healing or recovery time will be 3 to 4 weeks. I'm not totally positive on that. This is the first time I've done an emergency tonsillectomy on these subjects. As you know, we've only had them 3 to 4 months. So Do you think that putting them in the sterile environment will be enough precaution? Because I know with the immunosuppressants, their immune system is going to be a lot lower than what is natural.
Well, as far as with subject 4, who's not going to be receiving the immunosuppressants, I think they're going to be fine without using antibiotics afterwards and just keeping a close eye on if there's an infection by checking their temperature.
And that's the donor, correct?
Yes.
Okay.
And then for the recipient, to be safe, I feel as though they should still be on a broad-spectrum antibiotic just to make sure. And then also their temperature needs to be checked at least 4 times a day to ensure that there is no infection. And if an infection does occur, to put them on a stronger antibiotic.
Okay. Do you have the information on the blood type for subject 4?
Yes, subject 4 is type AB.
And the donor?
Subject 1 is type O.
Is there any RH factor we have to worry about?
There is not. We will be able to
Fantastic.
transplant.
Alright. Like Dr. Johnson was saying, we really need to watch out for the ischemic necrosis. I would hate to get a blockage in a blood vessel just because we didn't do the surgery carefully enough. Is there anything else that we need to add right now that we need to know about before we plan the surgery for tomorrow?
I think we're good.
Alright, fantastic. If I need anything, y'all are, I know where y'all are. You're in my basement, locked up, away, and Ethiopia. Dr. Shah, are we ready?
The patients are prepped and ready, doctor.
Alright. First we're going to start with the recipient. We're going to cut out the diseased tonsil. Dr. Emmanuelson, would you like to cut out the diseased tonsil? That was a beautiful incision.
Why, thank you. Alright, removing the diseased tonsil. Alright. Diseased tonsil is all removed.
Alright.
Dr. Austin, would you like to make the incision?
Make an incision on the donor. Removing one good tonsil. Alright, ready to go over to the recipient. Suture it. How are our stats, our vitals?
Vitals are good and stable, doctor.
Alright, the new tonsil has been inserted. I'm going to... Alright, we're now going to close up the donor. Oh! Keep behind! Do CPR! CPR is going!
Alright, charge, clear.
CPR again!
Charge, clear.
How are those vitals over there?
The vitals are looking good, doctor.
Alright. Do you see blood flowing into that tonsil?
Looks good.
It's good. Alright, let's close them up. Hi! CPR!
Charge, clear. Charge, clear.
Why isn't she responding?
Clear.
Alright. We got her back?
Got her.
Vitals are stabilizing.
Is blood pressure coming up?
It is, doctor.
Alright. Oh, that was scary. I'll close up the donor if you'll close up the recipient. There's your suture. Alright, looks like we're done here. Good job, everybody.
Alright. Alright, so surgery yesterday went very well with no signs of hyperacute rejection. Dr. Austin is currently monitoring the rat's vitals to make sure that stays the same. And Dr. Hilton had to rush back to Ethiopia, so we're just going to go over, how the rats are doing right now. Dr. Shaw, how are the rats?
The rats are looking very good, Dr. Emmanuelson. We're going to have to continue with follow-up visits to keep monitoring.
Okay.
We've already run a CDC. The white count is a little low, but that is to be expected.
Okay.
It's to be expected because they're on cyclosporine, which would lower the white blood cell count, and it blocks the T cell cytokine production by inhibiting the NFAT transcription factor.
Alright.
We're also monitoring the medication levels, and they are looking to be within the normal limits.
Okay, Dr. Gardner, what medications exactly are they on?
Right now they are just on cyclosporine and a general antibiotic because with their immune system repressed, then we're going to need to keep them on the antibiotics as long as they have to be on the immunosuppressors in order to ensure that there are no infections that occur as a result of having no white blood cells to fight off any infection.
Okay. Dr. Shaw, are there any other tests that we need to be running?
Yes, Dr. Manuelson. We've already run an ultrasound to check to make sure that the tonsils are looking healthy, and they are. And in 3 months, we're going to have to do a biopsy of the tonsils to make sure that they're still healthy and not necrotic, and that no chronic rejection has occurred.
All right. So just to recap, the antigens that are the targets for rejection are encoded in the MHCs, right?
That's
Yes.
true.
Okay. And then the individual who receives the transplants is the donor.
That's false.
That's false.
Okay. All right, good. So it looks like we are right on track for curing the worldwide epidemic that is on our hands right now.
Yay, let's cure the common cold!
You ready?
I'm ready.
Are you recording?
I am recording.
Perfect. Fantastic. Hooray! Woo! Why do you have a...
Because I'm in the lab and I have to have one to protect my rats from getting infected by stuff.
I'm
Right?
from Ethiopia.
What are you talking about? That's totally false.
Are we filming now?
Yeah.
Oh, these are your babies.
Oh my god!
You've been nursing them since they were little bitty babies. All right.
You should totally do
So
that.
once we get this research.
Sorry.